Watch the rock.
I'll call the meeting to order of the Commerce Committee. And we'll get started here. Our first order of business is the minutes from our February 18th meeting. I don't know, Representative Listlegard looks like he has a motion.
Oh, I have that motion, Mr. Chair.
Representative Listlegard moves approval of the minutes from February 18th, 2020. All those in favor say aye.
Aye.
Opposed, nay. Motion carries. The first item on the agenda today is House File 3228, authored by Representative Morrison, who can come on down. Welcome to the committee, Representative Morrison.
Thank you, Mr. Chair.
Since you are not a member of the committee, I will move to re-refer House File 3228 to the Government Operations Committee. And with that, I will turn the floor over to you to present your bill.
Thank you, Mr. Chair, members. House File 3228 would establish a Prescription Drug Affordability Commission to give the state the ability to limit how much residents pay for certain high-cost drugs. All of us will need a medication at some point in our lives. Some of us need medication every day. We're all aware that the price of prescription drugs has accelerated in a way that has put some life-saving medications out of reach for some Minnesotans. As a physician, I encounter this every day in my practice. The tragic case of Alex Smith losing his life because he was forced to ration the insulin he needed to live shocked many of us. Minnesotans are struggling to afford the medicine they need. Others are afraid that becoming sick will leave them bankrupt. Let me just share a couple of egregious examples. The cost of Bavencio, a new cancer drug approved several years ago, is about $156,000 a year per patient. A new muscular dystrophy drug came on the market for an eye-popping price of $300,000 annually. In 2016, the FDA approved a bladder cancer treatment that costs $12,500 a month or $150,000 a year. Even older drugs that have been on the market are not immune. The cost of insulin tripled between 2002 and 2013, despite no notable changes in the formulation. And the 4-decade-old EpiPen, a life-saving allergy medication, has seen a price hike of 500% since 2007. The out-of-control cost of prescription drugs has reached a point that action is required. The state has the legal authority and, frankly, the responsibility to take action to address this problem. Our bipartisan Prescription Drug Affordability Commission is one way to do just that. The legislation is based on a National Academy of State Policy model. Maryland and Maine have both passed into law and established prescription drug affordability boards. The commission would give Minnesota the ability to limit how much residents and state-regulated entities pay for certain high-cost drugs that present an affordability challenge to the state healthcare system or patients. The commission would examine the cost that a drug would impose on the healthcare system and patients and set a maximum reimbursement level, also known as an upper payment limit, that applies throughout Minnesota's healthcare system, from distributors to doctors, pharmacies, hospitals, insurers, and consumers. The commission is comprised of 7 positions, 3 appointed by the governor and 1 each by the majority and minority leads of the House and Senate. The members must have demonstrated expertise in healthcare economics and be free of certain conflicts of interest. The commission will then be advised by an 11-member stakeholder affordability council appointed by the governor based on expertise in areas including pharmaceutical business, medical practice, patient perspective, and the healthcare marketplace. The commission will have the authority to review the affordability of drugs that meet certain cost thresholds detailed in the bill, such as for brand name drugs and biologics, an increase in the wholesale acquisition cost of 10% or $10,000 during any 12-month period, or an introductory wholesale acquisition cost of more than $30,000 per year or course of treatment, or for generics, an increased wholesale acquisition cost of 200% or more. When a drug meets these thresholds, the manufacturer must report to the commission. The manufacturer, as well as other entities such as insurers and pharmacies, will have the opportunity to provide information explaining their prices. The commission is also required to consider public input and may rely on the advisory council for additional context and advice. Once the commission has decided to conduct a cost review of a specific drug, It may consider factors enumerated in the bill, including price, the impact on patients, drug-specific patient access programs, therapeutic alternatives, public comment, and more. If the commission finds that the reviewed drug creates an affordability challenge, it must consider the cost of administering and delivering the drug and other relevant costs when setting the maximum reimbursement level. This commission is based on two long-standing precedents. One, public service commissions exist in all 50 states, setting rates for vital services such as electric, natural gas, taxi, and telecommunication services, especially when there is little or no market competition. In Minnesota, the Public Utilities Commission is charged with setting rates for telecommunications and utility costs. Likewise, the Prescription Drug Affordability Commission will work to maintain or increase access to vital services and products. The legislation recognizes that prescription drugs are a public good and are universally needed, and that these critical drugs often have only a few suppliers. Second, the decades-old practice in healthcare of not paying charges for products and services, but rather setting payment limits or allowed amounts, which may be unrelated to list price. The concept of limiting payments is ubiquitous in both state and local government health financing programs, as well as in commercial health insurance programs. Currently, individual payers negotiate these payments or reimbursement limits with suppliers, such as provider groups, drug manufacturers, et cetera, resulting in a patchwork of prices and availability for patients. In the prescription drug space in particular, layers of complexity in the supply chain, lack of competition, and lack of regulation have evaded market forces and allowed for continuously skyrocketing prices. The commission would band together the influence of payers across the state to set reasonable maximum reimbursement levels for prescription drugs sold in Minnesota. Thank you.
Thank you, Representative Morrison, and I think you have some testifiers for your bill, and we're joined, I believe, first by our Attorney General. Welcome to the committee, Mr. Attorney General, and you have the floor.
Thank you, Mr. Chairman, and all members. It's an honor to be with you, and it's a particular pleasure to speak in support of Representative Morrison's bill. I would like to describe for you what I believe the bill would do to benefit Minnesotans. But before I do, let me give you a little bit of basis for that opinion. Last year, about this time, I convened a task force established in February 2019, and that task force came back with its full report today. We will be happy to supply you with the full report. State law prohibits me from sending you the full report, but if you ask for it, I will be more than happy to give it to you. And I think without even asking you, I can give you the executive summary, which I believe is in your packet. But we'd love you to read it. The report consists of experts on pharmaceutical drug prices, patients and their family members, medical practitioners, a representative of the Minnesota Board of Pharmacy, and Minnesota state legislators, including Senator Jensen and Senator Little, one Democrat, one Republican, and Representative Lesh and Hamilton, one Democrat, one Republican. And we also have Dr. Schandelmeyer, Stephen Schandelmeyer, who is a national expert on health economics, and Dr. Cody Weiberg, who's the chair of our Minnesota Pharmacy Board. In other words, we had the whole breadth of Minnesota. We have a bipartisan, bicameral recommendations, and today, House File 3228 is among those that we feel that deserve support. Throughout 2019, the full task force met 8 times, and with 3 working groups met numerous additional times. I conducted a number of community meetings in southern Minnesota, northern Minnesota, central Minnesota, eastern Minnesota, and in the Twin Cities. Numerous experts, advocates, industry members, state officials were brought in to provide information and advice on how to lower high drug prices, and members of the public were able to and did participate in each meeting. Listening sessions were attended by members of the task force, and as I noted, I had meetings all over the state, including Chaska, Wilmer, Mankato, Minneapolis, St. Paul, and many other places. And again, earlier today, the task force published a 91-page report, which I urge everyone to read, detailing, among other things, the dysfunctionality of the prescription drug market in the United States, discussing some of the major causes and contributors to high drug prices, and most importantly, making 14 recommendations on how to lower drug prices, the first of which is House File 3228. So let me describe what I believe are key factors in the bill, which I think would help lower drug prices for all Minnesotans. The bill would establish a commission to review and ensure drugs are priced reasonably and affordably, and that the price increases are justified. The bill would require drug manufacturers to provide certain drug pricing information about high drug prices and to justify those high prices and significant increases. And it would allow the commission to seek more information as part of the in-depth review of a seemingly exorbitantly priced drug or large price increase, and the commission would allow a ceiling or cap on unjustified prices or price increases. And finally, the commission would refer matters to the Attorney General's office if an enforcement action may be warranted. Now, I would submit to you that attacks on the legislation on the basis of constitutionality are wrong, and you should reject these ideas because they're not well-founded. Some challenges have made to legislation like this based on the dormant commerce clause, the legal problems that some other states have had, like, for example, Maryland is always used as an example, simply are not present in this legislation. And the reasons why is that this legislation does not link the state's regulation to actions occurring in other states. So, for example, a state law that required pharmaceuticals within the state to be priced no higher than prices charged in other states might face a dormant commerce clause challenge. This law doesn't do that. This legislation doesn't do that. And also, it does not impose costs on interstate commerce that are out of proportion to the expected benefit to the public. So, for example, other state that might have placed extra burdens on commercial trucks in one state and therefore making them cost prohibitive in other states may draw a challenge. This bill doesn't do anything like that. So I think that challenges based on constitutionality are not well-founded. And I think this is a strong piece of legislation that will help Minnesotans. The fact of the matter is that earlier today, Dr. Schandelmeyer shared with us that since January 1, 6 weeks ago, we have seen exorbitant price increases across the board. He noted that about 2,000 drugs have seen increases in prices since that time, about 95% of them above inflation, some of them as high as 500% above inflation. This legislation could address these problems and would help Minnesotans afford their lives. And so I urge you to consider it favorably. Thank you very much.
Thank you, Attorney General. I think Representative Mahoney, did you have a question you wanted to ask?
If I could, please.
Is it for the Attorney General or is it
Yeah,
for the? Okay.
For the Attorney General. Welcome to the committee. What is the penalty that you can assess to the pharmaceutical companies, and if they stay out of the state, do they stay out of your grasp?
Attorney General Ellison.
Mr. Chairman, right now, Representative, we have antitrust authority, we have authority for deceptive trade practices, and we have authority to address some of this issue. We have an active lawsuit going against a group of companies of generic manufacturers. And again, generics are absolutely going to tell you that they're the good guys and the brands are not. But the truth is, the problem is widespread, not just in one area. But we're suing a group of them right now who have engaged in a price-fixing scheme. That case is in litigation right now based on essentially an antitrust, anti-competition theory. We also are suing an insulin manufacturer on similar ground. The penalties that we can assess, are limited. I believe that they're not enough to, to dissuade any competitive practices. I think more is needed in this more enforcement tools are needed to bring prices into line. At this point, we have our resource limitation is such that we have to find some of the worst offenders and go after them. But this particular commission could operate in a more broad way and control prices more generally, as is done in many other industries. So we do have some tools, but we need more help, and this legislation, I think, would do that.
Representative Mahoney?
I'm just wondering if there's a drug company CEO who could end up in jail.
Well,
Attorney
it would be a
General.
civil act, Mr. Chairman, it would be civil action that we're talking about. But let me tell you, there have been drug company CEOs that landed in jail. I mean, most recently, there was a outrageous drug pricing fixing scheme that in fact did land, I believe, the CEO of Insys. Yeah, I think it was Insys. I think I'm having a little bit of time remembering exactly the company. It has happened, but that was due to a federal enforcement action, criminal enforcement action. But generally, the tools we have available in this area are civil in nature. But we do work with the federal government to try to gain compliance. It's just that this problem is so widespread and that we need more tools than we have available right now. And I would like to add this, Mr. Chairman, that my office is looking at devoting more resources into antitrust in the drug area. We've spent a year working on this, and we are going to be asking you to make some changes in law, but we're also urging our federal delegation to take action and the administration to take regulatory action, and of course the Attorney General's office. We're going to step up and do our part. We just can't have people dying because they have to ration their insulin anymore. It's just that's got to change. So I thank you.
Thank you, Attorney General. Thank you.
Thank you, sir, and I thank the committee. Thank you, Representative Morrison.
The next testifier that's on the list is Will Phillips of AARP. Thank you, Mr. Phillips. Yep.
Yep. Thank you, Mr. Chairman, members of the committee. My name is Will Phillips. I'm the state director with AARP Minnesota. With more than 650,000 Minnesota members, we at AARP appreciate the opportunity to testify in support of House File 3228, which establishes the Prescription Drug Affordability Commission to ensure drug prices are reasonable, justified, and support improved consumer access and affordability. Prescription drug prices are a high priority for AARP. Our members are 50 years of age and older. Many of them, just like everybody else, struggle every day to afford needed and life-saving medications. We know high drug costs hurt everyone, not only those who rely on prescription drugs for their health and chronic conditions, but all of us who are paying higher premiums and out-of-pocket costs for health insurance, as well as all of us as taxpayers who fund public programs. We're having an article passed out from the AARP Bulletin, which was published in 2017, that I think provides a good explanation of the issues that we're dealing with. And I'd like to say that the trends that we documented back then, 2 years ago, are no longer present today, but sadly, that's just not the case. Americans continue to see their prescription drug prices skyrocket, and as the article says, nothing stops drug companies from changing the highest price, or charging rather, the highest price the market will bear. The result are prices that make little sense, but lots of profit. About 30 years ago, the public was outraged over a drug cost less than $10,000 per year. And we now have drugs that are approaching $1 million a year. And a recent study noted that the average annual retail cost of prescription drug therapy for a specialty drug is nearly $79,000 a year, which is a number that's above the median U.S. household income and more than 3 times the median income for Medicare beneficiaries. So for years, our studies have also shown that drug prices are rising faster than inflation and quickly out of reach for our members. And moreover, older Minnesotans tend to take more drugs on average, typically 2 to 4 prescriptions to manage chronic conditions, so any increase can make these drugs unaffordable. So it's hardly surprising that our members rate this as a top concern year after year. And I want to share a few stories from some of our members, one of which is Claire Henn from right here in St. Paul. Claire's prescription for Remicade to treat her rheumatoid arthritis ballooned from $60 for a treatment to $1,400. And she was forced into a harsh trade-off that is all too common. She stopped taking her medicine so that she could afford her housing. Now that situation has been remedied, but she has been dealing with permanent long-term physical impacts as a result. There's Sue and Tom Counters from La Crescent. Sue has breast cancer and a prescription drug that's cost more than $240,000 a year. Now, they feel lucky because they have insurance, but even with insurance, their cost is $12,000 a year. They can afford it, but they worry that there aren't a lot of others who can. And we hear these stories every day, and we're going to be lifting up as many of them throughout the course of this legislative session as we can. So on behalf of all them and countless others, it's time for Minnesota to take action this year to rein in high drug prices. Senate File 3228 will allow the Affordability Commission, an independent body, to evaluate and set upper maximum limits for prescription drugs to protect consumers, to protect state and local governments and other stakeholders that create affordability challenges and limit access for patients. It's not unlike, as has been alluded to, how we set rates for other vital services such as electricity, natural gas, and telecommunications. So bottom line, we continue to hear stories like this. Bills such as this and others introduced this session can save us all money, patients, taxpayers, and our healthcare system, but most importantly, we believe they'll help ensure that Minnesotans have access to affordable drugs that they need to get and to stay healthy. So, Mr. Chairman, members of the committee, thank you.
Thank you, Mr. Phillips. The next testifier is Julie Intermill. Welcome to the committee.
Thank you, Mr. Chair. Good afternoon, Chairman Stevenson and distinguished members of the committee. My name is Jessica Intermill. I have copies of my testimony today if anyone would like to have them, but I thank you for your consideration of House File 3228. I appear today to support passage of the Prescription Drug Affordability Act because as a Minnesotan with a chronic illness, I know how crucial and how expensive prescription drugs can be. And as a small business owner, I see firsthand how the hidden costs of prescription drugs increase the cost of all of our care. My story started nearly 10 years ago when I was a healthy 31-year-old. My husband and I decided to have children, and about 4 weeks into my pregnancy, my fingers started hurting. Each day, my knuckles swelled a bit bigger, my pain deepened, and as the months passed, my wrists ballooned and the stiffness became so great that I could not make a fist. I was 7 months pregnant when I was diagnosed with rheumatoid arthritis. I went home, I cried, and 22 days later, I delivered our child. I've now had rheumatoid arthritis for about 8 years, and it's expensive. The primary driver of my care costs is pharmaceutical gouging. Just 1 year of my drugs, of just one of those drugs, is $46,000. That's 90% of the cost of my care. And it's about the same as a nurse's starting salary. And it's a cost that I have to incur every year for the rest of my life because without it, my joints will swell and stiffen, my mobility will decline, my pain will skyrocket, and I can't be the mother, the small business owner, and the citizen that others in our community depend on. To be sure, the drugs manufacturer offers insured patients copay assistance to help bridge patients' costs in their high deductible plans. Manufacturers know that patients can't afford to pay thousands of dollars for just one dose. They know that patients like me are likely to skip doses and stretch doses instead, and that will cause fewer drug sales. So I appreciate that this year, the drug company paid $3,500 of my $4,000 high deductible plan, and they did that in January. I have already met my high deductible for the year. But that cost is just one piece of a puzzle that keeps people in the dark about the true cost of pharmaceuticals. In 2020, I will pay my insurer more than $13,000 in premiums, in deductibles, and out-of-pocket expenses for the health care for me and my daughter. But our total family cost is even higher because my husband is on a separate plan. My plan, my insurer, pays $46,000 a year to the drug company, and the insurer passes that cost back to each and every one of us in higher premiums and out-of-pocket costs. This year, my small business will pay almost $11,000 per month in premiums for just 9 employees and our families. Each step in this shell game ratchets costs higher, but we never stop to ask, why does just one drug cost $46,000 per year, more than $125 per day? We never stop to ask that in the first place. That's why we need this Prescription Drug Affordability Act. That's why we need Minnesota to establish a commission that will ask that question, demand transparency, and begin the hard work of containing these out-of-control costs. Thank you for your consideration, and I ask for your support of this bill.
Thank you for your testimony, and I apologize for getting your name wrong at the outset. The next testifier is Catherine Iliff. Welcome to the committee. Did I pronounce your name correctly?
Amazingly, you did very good.
I had good advice. Thank you.
Mr. Chair and members of the committee, thanks for having me here today to share my story. My name is Catherine Iliff, or Beadle to friends and family. I'm from Minneapolis. I have been a registered nurse since 1973, and I love to help my community. In my spare time, I take my dog Blondie to the Minnesota Veterans Home, and I also volunteer as a guardian ad litem for children in protective services in Hennepin County. I don't do this often, so my heart's pounding. I enjoy serving my community, and that's why I'm here to ask you, I'm here to speak out about the high cost of drugs. In my work as a nurse, I witnessed the evolving healthcare landscape and its effect on struggling Minnesotans. I saw firsthand how expensive drugs impacted my patient. I had no idea the issue would soon be pervasive in my own life. I live with 2 autoimmune diseases that require expensive medicines to manage. I need these medications in order to function in day-to-day life, play with my grandkids, serve in my community. But since I'm on a fixed income, affording my treatments can be difficult. I have to ration one of my medications, Lyrica, because it costs $300 a month. I can't afford it, and I don't know anybody who could. Instead of taking the medicine as prescribed, I have to skip doses and live with the symptoms. These prices are unsustainable, and it's cruel that the pharmaceutical companies can get away with pricing drugs right out of the reach of Minnesotans like me. We need our state to change the rules. HF 3228 would prevent the drug corporations from charging exorbitant amounts for drugs and raising prices every year. It would give bipartisan commission the authority to set maximum prices, which will save money for the patients and the state. There are so many families like mine all over the state that are crippled by the cost of their prescription drugs. Drugs don't work if people can't afford them. I strongly urge you to vote yes on HF 3228 and to protect me, my grandkids, your kids, and the other Minnesota people who struggle with high drug prices. Thank you.
Thank you for your testimony. Appreciate it. That concludes the list of testifiers on behalf of the author. We'll now open up for testimony from the public. We do have a couple people who have signed up in advance, but after that, we'll take testimony from anyone else. We're asking all members of the public who testify to limit their testimony to 3 minutes, and make sure to state your name before you begin your testimony. But we do have 2 people who signed up in advance. The first is Sharon Lamberton. Welcome to the committee.
Good afternoon, Mr. Chair, members of the committee. My name is Sharon Lamberton. I'm with the Pharmaceutical Research and Manufacturers of America, a trade association of 38 member biopharmaceutical companies in D.C. I'm proud of the scientists that are working really hard every day to come up with new cures and treatments for patients. We've spent over $900 billion since 2000 to come up with some new life-saving cures. I'm a registered nurse by training, and access to these medicines is very important, but as I've said before, it doesn't matter how many life-saving cures we have if the patients can't access it and afford it. Pharma supports reforms that put patients first, solutions that ensure patients have access to these medicines, and that they can make informed healthcare decisions while preserving the ability to find new and better treatments. However, respectfully, HF 3228 that proposes the development of the Prescription Drug Affordability Commission misses the mark. Instead, it recycles failed ideas that government broad authority that allows them to have arbitrary price settings of maximum reimbursement limits or caps. It undermines the competitive market of our system that's critical to bringing down costs and delivering these new medicines and treatments to patients. First, patients in other countries that implement price controls face delays and challenges. Just taking, for example, cancer treatments. Americans can access almost all cancer treatments here in the United States before the other developed countries and other nations. This legislation would create challenges, and instead of solutions for patients, would be problematic to accessing some of these treatment options. Furthermore, the commission's to consider cost effectiveness of the drug, which is problematic because cost effectiveness is often used to drive coverage and reimbursement. And even if safeguards were to be implemented, like an appeals process or something that would help mitigate some of these potential effects, these types of processes have been shown to burden healthcare providers and patients. And it results in delayed treatments to getting access and can result in devastating consequences. Also, this bill seeks to establish maximum reimbursement levels, as we discussed, but pharma believes that it does violate federal constitutional principles as examined in the 1997 case, Bio versus D.C. The court overturned a D.C. law imposing price controls on branded drugs, reasoning that the D.C. law at issue conflicted with the underlying objectives of the federal patent framework and undercut the company's ability to set prices for patented products. We believe that the D.C. rate-setting law at issue in this federal circuit case, HF 3228, would similarly obstruct the underlying principles of patent laws and could suffer the same fate of being preempted by federal law. In addition to the maximum reimbursement rate on patented drugs, there could be out-of-state effects such as dormant commerce clauses. I know my time has come to an end, but I know you'll hear from others. This law will have a chilling effect on innovation. We have over 43,000 jobs that the industry supports here in the state of Minnesota and over $686 million of tax revenue. This bill also places that in jeopardy. Thank you for your opportunity to present, and I'll look forward to any questions.
And Ms. Lamberton, a couple of members have indicated they do have questions. Representative Howard.
Thank you, Chair. Ms. Lamberton, I just have a few questions based on the letter that was submitted in your testimony. First, you referenced that $900 billion since 2000 has went towards research. I'm just trying to understand the scale of what dollars are going where. Could you tell me how much money those same companies have spent on advertising and lobbying in that time?
Ms.
So-
Lamberton.
Yes, Mr. Chair, members of the committee, Representative Howard, I do know that our companies file every year the different expenditures down from administrative costs to general expenditures, pensions, revenues, DTC that's spent on advertising. They also have the itemized costs in the filing. So that information could be found by company. We are the trade association, so I couldn't speak to one company, but certainly that information is publicly available for a breakdown.
Representative Howard.
So, Ms. Lambert, you have the number, this 900 million. I just want to, so that's for all the companies, but you don't have the figure.
It's
for the-
900 billion
900
for
billion,
all
yeah.
the biopharmaceutical companies in the country, and that's an aggregate number. But again, the SEC filings have them.
I'll just call it, okay, I'll just call attention to a study that says 9 out of 10 companies do spend more on advertising than they do on research. And you mentioned in your testimony new cures. I'm wondering, of those new cures, how much funding did those companies receive from the National Institute of Health, public funding for those new cures?
Ms. Lamberton.
Mr. Chair, members of the committee, the National Institutes of Health, where I worked for several years as a clinical research nurse, provides critical basic research. But it often is not that basic research that will bring the cure over the finish line, if you will. It's important that our private sector continues a lot of that innovation. As far as a breakdown, I'd have to get back with you on what particular company or cure you're looking at, but it's so exciting to see that 7,000 new medicines are in the pipeline into development. And when you look at a medicine costing over $2.6 billion to bring a cure from bench to bedside, and only 12% to make it, 88% of medicines fail. It's a risky and expensive proposition that our industry is in, but we're in it to bring life-saving treatments to patients so that people can thrive.
Representative Howard.
Thank you, Mr. Chair. And I don't have the global numbers. I do. There's a study that from 2010 to 2016, of the 210 new drugs that came to market, all 210 received funding through the NIH. Ms. Lamberton, you mentioned that this legislation would undermine the competitive market. I'm wondering, can you speak to which of your member companies engage in pay to delay and how that affects the competitive market?
Ms. Lamberton.
Mr. Chair, members of the committee, when I said that it would undermine the competitive market, I truly believe it. You look at other countries that have implemented price caps or reimbursement rates, set rates, and you look at the delay in innovation. There are multiple studies that I'm happy to provide the committee that show that access to life-saving medicines is often up to 8 years of a delay, where a patient in the U.S. would get a delayed treatment of the patient counterpart in another country. So they have some devastating consequences when you look at the caps and how that it could delay treatment and innovation.
Representative Howard.
Mr. Chair, Ms. Lamberton, my question is about what's commonly referred to as paid to delay, where a brand name manufacturer will pay a generic not to bring a product to market, which prevents an affordable drug to come to the market. And my question is, how many of the companies that are part of your trade association have engaged in that practice, and what is that impact on the competitive market?
Ms. Lamberton.
Yes, Mr. Chair, members of the committee, I do know that that's often a misnomer. Pay to delay is not necessarily what is actually happening, even contrary to public opinion, that pharma and our brand associations are supportive of getting generics to market. When you look at the patent cliff just between 2019 and 2023, we'll have over $95 billion lost in sales because generics and biosimilars are coming to market, which is exciting for patients because they'll have reduced cost treatments. So that's something pharma is actually supportive of, and our member companies are supportive of, but we do not engage in paying for delaying treatments. This is not our business. We're in the business of bringing cures and treatments to patients.
Representative Howard.
Mr. Chair, then Ms. Lamberton, would I be correct that your organization supports pay to delay legislation at the federal level?
Ms. Lamberton.
So, Mr. Chair, members of the committee, I would like to get into more of a discussion on how you're defining pay to delay, because that's not something that we do. that we are in the market of we're trying to innovate and come up with medicines that will bring cures.
Representative Howard.
All right. Well, I just wanted to ask a few of these questions that sort of get at the rules of play, if you will, for these companies and for Minnesotans. And this there's probably no issue when I talk to folks at the door that cuts through the partisan divide than the cost of their prescription drugs. And right now, we have rules that benefit the drug manufacturers. We don't have rules that benefit Minnesotans. And this piece of legislation, I thank Representative Morrison for bringing it forward, puts a tool in our box as legislators to represent our constituents and make sure that Minnesotans have power to bear when it comes to their cost of prescription drugs. Thank you, Mr. Chair.
Thank you, Representative Howard. Representative Dean.
Thank you, Mr. Chair, and thank you, Ms. Lamberton, for being here. I'm going to ask you a question that I know you won't be able to answer specifically, but I'm assuming you're familiar with a lot of the business models of many of our pharmaceuticals and distributors and things like that. What is the cause of one drug from going for a month's prescription of $40 one day, and the next day it goes up to $1,400? I mean, what are the factors that would play into that large of an increase for the same drug, same delivery, same everything? If you could explain that, I would appreciate it.
Ms. Lamberton.
Mr. Chair, members of the committee, I appreciate your question on what factors go into pricing a medication. As PhRMA, the trade association, I don't price products, nor does my organization. We represent the 38 biopharmaceutical companies, but I do know that they look at in multiple factors. I'm happy to provide you and the committee with some of those factors that is considered, which is prevalence of the disease condition, how much of the patient population would be treated, what are the existing therapies that are out there that are treating that condition, what are the offsets, which are many, to using medicines appropriately, how many hospitalizations, emergency room episodes can be averted due to that treatment. Host of factors are taken into consideration when pricing a medication that will bring patients hopefully some life-saving, life-improving conditions.
Representative Dean.
Thank you, Mr. Chair, and Ms. Lamberton, I appreciate that. You know, you're here representing PhRMA. And as I mentioned, I'm assuming you're familiar with business models and those impacts. You've named several factors, but we had someone who recently testified that their medication went from $40 a month to $1,400 a month. So something happened within a 30-day period for that particular drug manufacturer or distributor or somewhere along the process that caused an incredibly large increase in those costs. And, you know, I'm still trying to wrap my head around this payback and the rebate part of this industry that I just think is, you know, I mean, pardon my French, but it's kind of wacko. You know, if you have a cost associated with something, that's what you should charge. And if you're giving rebates, you know, that means that maybe you're charging too much in order to hopefully not give rebates to everybody, and then you end up profiting that. So if you could just, again, try to give me an example or, you know, reports out there that can speak to how a particular medication would increase that drastically within a 30-day period.
Ms. Lamberton.
Mr. Chair, members of the committee, I appreciate your question. When you look at rebates, our biopharmaceutical industry provides over $166 billion in rebates here in the state of Minnesota. It's $527 million to the state that our biopharmaceutical industries pay to the state. So we are contributing quite a bit in the system of supply chains from where the medicine goes from the pharmaceutical manufacturer all the way to the chain drugstore, all the supply chain stakeholders like healthcare plans, PBMs, everybody gets a cut or a portion of the rebate. But our problem is that we don't see the patient getting any relief at the point of sale, which is the pharmacy counter. These are solutions that I believe we could bring to this committee. We have 4 of them. One of them is sharing the savings, making sure that these rebates get to the patient so that they can use it. Your question on specific business models or referring to the patient who talked about the significant increase in her price of medicines going up from day or month to month, I am not able to speak to, of course, being the trade association, but I do want the committee to respect and understand the supply chain structure that we're all dealing with, and that we do have some immediate solutions we would like to work with you all on to get some of that rebate money, that real dollars, to relief for patients so that they can have access to these affordable medicines.
Representative Dean.
Just a last comment. Rebates aren't things that pharmaceuticals are doing out of generosity, that's coming because they've already received that money in some manner or another, and it's getting redistributed in weird ways out there. So if you don't receive those money, then you wouldn't have to redistribute that money, and that would lower the cost overall. But I'm sure I'm thinking this from a very simple perspective, which I think we would be better off if we looked at the pharmaceutical marketplace and healthcare from a much simpler point of view than, doing 20 or 30 different ways of pricing. So just a comment. Thank you, Mr. Chair.
Representative Listlegard.
Thank you, Mr. Chair. And, maybe I'm even a little more simpler than that. My question is, does your members supply other countries worldwide?
Ms. Lamberton.
Mr. Chair, members of the committee, our biopharmaceutical companies, they do sell product to the United States and other countries.
Representative Listlegard.
Mr. Chair, thank you. So how can other countries charge less than our country? And how is it that I know senior citizens and elderly people that they go down to Arizona and they have insurance, but yet they go across the border to get their prescription because it's cheaper even when they have insurance here? How is that possible?
Ms. Lamberton.
Mr. Chair, members of the committee, you are correct that there's a completely different pricing structure set up and payment structure for medications in the United States than the other developed countries. We do pay other countries and work with other countries differently. Those are trade laws that are way above my pay grade and my knowledge, but it deals more of it on the federal level of pricing of medications. But I will say, when you look at spend on prescription medicines between other countries, you can look at a number of those factors here. Just spending on prescription drugs in Minnesota in Medicaid, which is what we're talking about here today within the state, is only 3.6%. You've got to look at the other healthcare sectors like long-term care and hospitals, and look at how prescription medicines are still a smaller part of that microcosm.
Representative Listlegard.
Thank you, Mr. Chair. So you said a really big number, 900 billion.
Yes.
Is that correct?
Oh, sorry. Mr. Chair.
Yeah, Ms. Lamberton, sorry, thank you.
Members of the committee, yes, correct that $900 billion for biopharmaceutical contributions to research and development since
Representative
2000.
Representative Listlegard.
Mr. Chair, so would it be fair to say that if United States citizens, wherever they're at, we don't have the same deal or the same trade agreement as other countries, that the $900 billion investment, that all the research that the United States and our state is paying the majority of that research, and the rest of the countries are getting a better deal?
Ms. Lamberton.
Mr. Chair, members of the committee, I don't know that hypothetical on what would happen if pricing structures were different here in the United States, what the research and development budget would change, how it would change. But right now, I'm so proud of the innovation that's occurring. And if that R&D, many of these prices that we're talking about for treatments, as we mentioned, 88% of them fail. And that money, that of those that are successful, of the 12%, do go back into the system and fuel the future innovations. It's a very complex system, I know, trying to understand for even me, looking at how research and development breaks down in new innovative treatments. But I am very happy with the access as a nurse and as someone that works for pharma on what patients are able to get because of the hard work of our scientists.
Representative Listlegard.
Mr. Chair, and I truly appreciate all the research, and it's improving people's lives. But it's the cost, to us. And so my question, this is just, I don't know if it's a statement or it could be a question. Do you think that if United States had the same deal through your organization and your members as Mexico does, that you'd be able to invest $900 billion in research if we had the same agreement and paid the same as Mexico?
Ms. Lamberton.
Mr. Chair, members of the committee, I appreciate your question. I'm unable to answer what the research and development budget would be if we had the same structure as Mexico. But just to the point of what immediate relief we have for Minnesotans, we do have a program I have not addressed here, which is called Medication Assistance Tool, www.mat.org. It is a one-stop shopping to over 900 public and private programs that offer free or nearly free medicines for patients or healthcare providers or to their caregivers. And that's an important element where our companies are going above and beyond trying to provide product to those that can't afford it, whether they're insured or uninsured. And that's important for us to know for constituents of Minnesota and patients.
Representative O'Neill had a question to this point.
Thank you, Mr. Chair. You know, we've been talking quite a bit about a lot of things, and there's lots of questions. Unfortunately, they're not about the bill, and I'm wondering if we can come back to solving this. Obviously, we've established there's a problem. Okay, great. Let's talk about the bill, which is the commission and the related advisory council, because most of these questions are related to other things, and if we could talk about the solution, which is in front of us, and the mechanics of that solution, and the mechanics of how this commission would work or not work, and the advisory council and how it would work or not work, because we have limited time, Mr. Chair, and I think that we've gone far afield enough. If you could bring us back to the actual content of the bill and the components of the bill.
And
Thank
thank you, Representative O'Neill. We do only have one more questioner on the list, so I'll let that representative ask their questions of Ms. Lamberton if he has any. Representative Elkins.
Thank you, Mr. Chair. In the pharma statement, it suggests that revealing prices could have, harmful or anti-competitive effects. I've been doing a lot of homework on this. I'm an economist by education, and I'm not aware of any study in any area of healthcare suggesting that increased pricing transparency would have anti-competitive effects. So I don't expect you to know the answer to this, but if you are in fact aware of any studies that would back up the contention that greater pricing transparency would have anti-competitive effects, I would love to have an opportunity to read that.
Thank you, Ms. Lamberton, for your testimony and for answering the committee's questions. Yeah, and thank you. The next testifier on the list is Judy Cook. Thank
Good
you, Ms. Cook.
afternoon, Mr. Chair, members of the committee. My name is Judy Cook with Cook Gerard Associates, representing the Association for Accessible Medicines. That is the generic and biosimilar prescription drug manufacturers. Just want to remind you, I think I said this a few times last year in here, but generics represent 90% of all drugs dispensed in the U.S., but account for only 22% of total spending on prescription medicines. AAM understands your interest in addressing drug pricing and want to work with you on that, both for patients and the state. We've talked with Representative Morrison and look forward to working with her on this. As we've done with other legislation, I'd like to report that just in the past couple days, we have reached an agreement, an understanding where we have removed opposition to her drug price transparency bill, and appreciate the opportunity to work with you on that. However, as the bill is before you today, AAM opposes House File 3228. As you look at drug prices, I want to remind you that generic prices are in a period of deflation beginning in 2016, and for 39 of the last 41 months, overall generic drug prices have decreased. California report last year from health plans, generics accounted for only 2.8% of premiums across total health plan costs. The 25 generics with the highest price year-over-year increases accounted for only 3.8% of total annual spending on prescription drugs. The issue of rebates has come up, and I just want you to know that other than rebates required by the Medicaid program, generic manufacturers do not pay rebates on their products to get preferred formulary placement, and we do not market our medicines. But generic products are now losing preferred placement as they compete with ever-increasing brand rebates. And this is evident actually in our Minnesota's preferred drug list for public programs and on Medicare Part D. To date, Maryland is the only state to enact a bill that would allow the state to set drug prices like this bill. In Maryland, AAM worked with legislators so they understood the value of generics in their overall spending, and the legislators came to understand that generics are not driving their drug spend and were willing to set thresholds for review of generics that would only capture data on those drugs with price increases that could have a meaningful impact on patient out-of-pocket costs, premiums, or the state's spend.
This bill has a number of differences from the Maryland bill, including the stakeholder council, thresholds, notifications, and other items. So AAM opposes this bill to set prices in a way that does not recognize the value and cost savings that generic and biosimilars provide to Minnesota customers. And we look forward to working with Representative Morrison on this, and I'm happy to answer any questions.
Thank you, Ms. Cook. Representative O'Neill.
I'm going to come around so I can actually look at them. So, excuse me. So I have actually a series of questions for the author when we're ready for that. Do we have a whole bunch more testifiers after this?
This is the last testifier on the list, Representative O'Neill. I'm going to invite any member of the public who wants to testify, but if you have questions for the author, I'd encourage you to hold them for now. But if you have questions for Ms. Cook, you could ask them now.
I have questions for the authors of the mechanics of the actual bill and how it works, how it functions.
Okay. Well, then why don't we see if there's any other testimony, and then you
All
can take those questions. Representative O'Driscoll.
Well, thank you, Mr. Chair. I was not kind of unsure of how we were going to handle questions today. At different times, Chair Halverson would say, let's take all testimony and have questions at the end. I know we were taking questions along the way. I guess I'd like to, if when the time is right, recall one of the testifiers today, because I have some specific questions. So if you can let me know when the appropriate time for that is, I'd appreciate it.
Certainly. Thank you, Ms. Cook. That concludes the list of people who signed up to testify. Are there any members of the public wishing to testify on this bill? Seeing none, I think we can maybe start with Representative O'Neill's questions, and then we can move to Representative O'Driscoll and anyone else.
Thank you, Mr. Chair. So to the author, I didn't mean to have my back to you the whole time, but it's an awkward spot there. So anyway, I'm concerned, and what I want to know is there any, once this commission is established, is there any additional legislative oversight or oversight by the courts after it's established?
Representative Morrison.
Mr. Chair, members, there is an appeals process that the pharmaceutical industry can undergo, and I believe that there is a report to the Commissioner of Health annually, but there's no mandated court oversight unless a lawsuit became an issue.
Representative O'Neill.
Thank you, Mr. Chair. So the answer is no. So the appeals process is within the commission itself. As I read the legislation, it says that you can appeal, but you appeal to the same body that rejected you or whatever. So there isn't any legislative oversight. There is no court oversight per se. And the testifier from AARP likened this to the PUC. So I know a little bit about PUC. There's a few members here that know a little bit about PUC. So, for example, the 5 PUC commissioners and a very deep staff, a very large staff, when they're doing, for example, a rate case for electricity. So we have 3 IOUs in Minnesota. And there are some others that they do rates for, but let's just start with the IOUs. So for example, Xcel Energy. For them to resolve a rate case, it takes a minimum of 18 months. And it's a very formal process. There's a lot of testimony back and forth. There's a lot of lawyering back and forth. There's in-depth studies. And I don't see any of that in your bill. I don't see anything other than these unpaid, unelected members that will not just be handling something like the PUC does. Well, I mean, they do more than just, rate cases, but I'm just not sure how does this work. So can you give me some of the depth? If it's likened to the PUC, I don't see that in your bill. Can you help me understand what it does and how that functions? Do they have staff? If they're not paid, how does that work?
Representative Morrison.
Mr. Chair, members, there are elected officials on the commission. The governor appoints 3, and then the Senate and House minority and majority leaders appoint. And let's remember, too, that this is just addressing the outliers. So this does not, all drugs are not reviewed, just the very expensive drugs that are causing affordability challenges are reviewed. There's an 11-member advisory panel that it will be made up of experts in the area and patients. Pharma will be at the table. And so I think there's been a lot of thought put into how to review and how best to come to the conclusion to create limits so that people can afford the medicine that they need.
Representative O'Neill.
Thank you, Mr. Chair. So no, there's no staff. There's the advisory board, who are also unpaid. I mean, you're talking about an exorbitant amount of hours to really do this correctly. That's concerning. So let's go to the politics of it, as you did mention that. So if the governor appoints 3, and they're 4-year staggered terms, and the legislature gets to appoint 4, and it's 1 minority House, Senate, and 1 majority House and Senate. So regardless of the makeup of the House and the Senate, you're going to have 2 Republicans and 2 Democrats that get to appoint. And then whoever the governor is, whichever party will put 3. So kind of looks like the governor's party kind of trumps the appointments. And what it looks like to me, and this is like another committee I had just had the same conversation in last week, this is really silencing the minority, whoever the minority is. If whoever the governor is really gets to kind of rule the roost here in appointing folks to this commission that's going to decide these very important things. Again, not paid, so I'm not sure how they're going to be able to do that, because you're talking about a whole lot of time. I mean, again, it was likened to the PUC, and I know how that operates, and that is a lot of time. If you ask those commissioners how much time they spend, it is a lot of time, and they are well compensated for that, by the way. That's basically their full-time job. So I'm having a really hard time understanding how this doesn't become incredibly political, the way that it's structured. Silencing the minority voice. How do you even accomplish what you're trying to do with uncompensated commissioners, if that's what we're calling them, with no staff? I don't see how this works.
Representative Morrison.
Mr. Chair, members, I would like to think that the cost of prescription drugs is not a partisan issue. All of us become ill, all of us require medications. Some of us can afford them and most of us cannot. And so we've listened for years now to the pharmaceutical industry talk about trade secrets and talk about free markets and talk about patent protections and rebates and patient assistant programs, and the price of prescription drugs continues to rise. And so we need to try something different. And I think this is an excellent starting point. This is the Attorney General has been looking at this and studying this all over the state, talking to experts, talking to patients for a year. This is the #1 recommendation that comes out of his Drug Price Affordability Council. It may be that it needs to evolve over time, but boy, I think the people of Minnesota deserve a shot at being able to afford their medicines.
Mr. Chair, just a final comment.
Yep, Representative O'Neill.
Thank you, Mr. Chair. I don't disagree that drug prices are exorbitant. I'm just saying I don't know that mechanically this works. I mean, I've been here a little while, and I know quite a bit about how the PUC works. And it takes a lot of man-hours to do what they do. And I have to think that making a decision on the cost of a drug is going to be equivalent to deciding someone's electric rate for Xcel Energy. I see that as an equivalent. So unless in fact, it was likened to by AARP. They're the ones that brought up and said, well, this is just like the PUC. I'm saying if it is, then I'm not seeing that in your bill. Thank you, Mr. Chair.
I don't know, Representative Morrison, if you want to comment further.
Thank you, Mr. Chair, members. I guess I would just say it's likened to the PUC in that it's recognizing that prescription medications are a public good.
Representative Driscoll.
Thank you, Mr. Chair. I was wondering if we could have Attorney General Keith Ellison return, because he had a couple of comments that I wanted to follow up on. I also had some questions I wanted to ask him.
Representative Driscoll, I think the Attorney General has departed. I don't know if his staff is. There's an Assistant Attorney General. Would that be useful to you? We did take questions for Attorney General Ellison after his remarks, so there was an opportunity.
Well, I know that, Mr. Chair, a member asked a question, but you didn't indicate that we were going to be able to continue to ask questions, because you went right on to the next testifier. So I thought we were following past protocol where we wait till the end. That's why I questioned earlier.
Would you like to address questions to the Assistant Attorney General, or?
I guess I would feel more comfortable asking the Attorney General than to ask the Assistant Attorney General to speak on behalf of the Attorney General to interpret his comments and his statements. But, Mr. Chair, I will make these comments, though. I am concerned about a number of things relative to this bill. Number one is, as Representative O'Neill has pointed out, and have others, some are suggesting this is like the Public Utilities Commission. How this is starkly different and kind of following the same model is that these are regulated utilities which have a zone or a region in which they are able to do business. So they are restricted with competitors in that. This system will not allow for restriction of competitors. It will actually pit one competitor against another in front of an appointed commission with no staff, rendering an opinion that has the force of law. And that's a little bit scary to me. If I'm a person who is unable to afford my medication right now, because I have no idea what that unaccountable group would do. Secondly, it was stated by the author that this is just going to be around the edges, that this is just going to be for the high-priced drugs. Who determines what the high-priced drugs are? Who determines what the wheelhouse is going to be for the jurisdiction of this committee? I think we've got a lot of unanswered questions, and there's an old adage, be careful what you ask for because you might just get it. Thank you, Mr. Chair.
Thank you, Representative Driscoll. Representative Tice.
Thank you, Mr. Chair. And to the author, Representative Morrison, I probably just have comments. As somebody who has type 2 diabetes, and I've been going through quite a learning curve about the drug situation and what it means. I have a lot of concerns. I know people scoff when they say that companies will say that, R&D will go down. Wow. I'm not happy about that at all. When I look at the different drugs from some of the different companies, I'm like, wow, does it ever make a difference to me? I started out pricking my finger every single day. Now I do it either once every 10 days or once every 14 days, depending on what my PBM tells me I have to use to do it. So I'm either using Freestyle Libre or I'm using Dexcom. I use my phone. I know my blood sugars at any moment. All I do is look at my phone. To think that something like that would no longer be available because we're putting R&D at risk scares the bejesus out of me. I also look at some of the injectables I take. I don't do insulin, I do injectables, but I look at, I was on Victoza doing it once a week. Now once every day, I'm sorry. Now I'm doing Trulicity once a week. It might not sound like a big deal, but for this person who hates getting pricked, that's a big deal. And if I think something like that might not happen, R&D is going to make it a little less possible, yeah, that makes a big difference to me. I just really have a bad feeling about the bill. And as Representative O'Neill said, I have very big concerns about how it's going to go. When I look at some of the comments from the statements we have, where there's concerns about it ignores the variety of stakeholders, are we really considering the role that PBMs put in this? Because I will tell you, PBMs probably regulate what I pay for my prescriptions than anything else. When we talk about generics, I use mostly generics. In fact, my PBM has said I can only use generics if it's available. There are times when the name brand is cheaper with the rebate, and my pharmacy has told me that. So I still do what my PBM says. I also look at some of the reasons they talk about with sorry, it's a new day with my new Invisaligns, and I have a hard time sometimes saying words. So, yeah, right. Thank you. So I'm going to try to say disincentivize. That just, I can't tell you how much that really causes me concern. As Representative O'Driscoll said, I really feel it's kind of like we want to poke pharma in the eye. I get that. Drugs are expensive. I know. But at the other hand, my healthcare has changed a lot just because of the innovation that we see. And to think that there might be something that happens there really concerns me, truly concerns me, because this is what I deal with. I'm not dealing with some of the other things out there. I'm not dealing with some of the cancer treatments and things, the innovations that we've made, how treatments have changed since I've been alive. I'm not going to tell you how long that's been. But to think that we might stifle that, I just have a hard time with that. I think the transparency bill is a better way to go. This scares me. It really does. I don't know that you're going to get what you want. You're putting another buffer in there. To me, I'm just hearing my prices are going to go up. Because now, if you say, okay, this drug has to be at this price, and the company says, no, it's not, I'm not going to do it in Minnesota, then what? I have to go back to pricking my finger? I don't know. And that, to me, is a very scary proposition. So with that, there really isn't a question in here. It's just, I'm not very comfortable with the bill.
And I'm glad Representative Tice brought up PBMs, because our next bill does relate to PBMs coming after that. And I just wanted to alert the committee that we do have one other bill on the agenda, and that there are testifiers on that bill from Greater Minnesota who are here today. So we do have a hard stop today at 4:15 due to both parties having caucuses this evening. So we'll just keep that in mind. We only have one other member on the list currently, Representative Mahoney.
Thank you, Mr. Chair, and to the author. In some respects, I have some concerns in the same fashion that you're asking 11 people to do a significant amount of work. You know, we in government always believe that nobody's value is worth paying them, and I don't quite understand that, whether it's our employees or the people who volunteer for us. They get them $50, I think it is, per meeting. This is really big stuff. This would affect how so many people are able to live their lives. And is it going to be easy? Absolutely no. Is there going to be changes, whether it's a diabetic or a cancer or anything else? Yeah. And I really feel that we could do better if we actually paid the commissioners, whether it's part-time work or whatever. But if we're going to ask people to do the amount of work that is likely to have to be done, very similar to the PUC, to say that they get a $50 stipend, that would make for a lot of short commissioners, because we've done some of that. So I would hope that at some point between now and the time that the governor signs this, that you take a look at how we actually are going to pay these folks and give them the staff that they're going to need. Because we can't afford to continue to do what we're doing with these drug companies. The drug companies come in and charge $60,000 for one cancer treatment. And they got to do 6 of them or do 9 of them. So all of a sudden, for a cancer treatment, it could be $350,000, $400,000, $500,000. And that's an awful lot to get through. So I guess I'm asking you to take one more look at how you would pay these folks and staff these folks, because if we don't have decent staff feeding them the information that they need to make a good decision, we'll get bad decisions, and it'll end up on top of the fold. We had a mess up here, and it'll go away. And that's not good. We have too many people, I have too many people in my district who can't afford their medications and don't take their medications because of that. And I want those folks to have the longest, best life possible. So that's my words of advice. Hopefully you'll take them up, and if you don't, I'm still voting for your bill.
Well, and thank you, Representative Mahoney, and that concludes our list. So unless, Representative Morrison, you have brief closing remarks, we can move to a vote.
Thank you, Mr. Chair and members, and thank you for hearing the bill, and thank you for all of your comments. I'm open to working with everyone on this bill, both sides of the aisle. Everyone's input is important, stakeholders, You know, my dad always said nothing worth it is ever easy, and I think this is something that's worth it to try to figure out how we can make medicines affordable to Minnesotans who need them. Thank you very much.
Thank you, Representative Morrison. And at that point, I will renew my motion to re-refer House File 3228 to Government Operations. All those in favor say aye. Aye. Opposed say nay. No. The motion prevails, and you're on your way. The next bill on the agenda is House File 3223. Representative Schultz. And if people who are leaving could keep their voices down so that we can try and continue on. We don't have much time. Representative Schultz, the floor is yours.
Thank you, Chair
Oh,
Stevenson.
excuse
and
me, I did not move the bill. As you are not a member of the committee, I will move that House File 32. Yeah, and if we could, yeah. No, I appreciate that, Representative Davids. And I will move to re-refer House File 3223 to the Health and Human Services Policy Division. And with that, the floor is yours.
Thank you, Chair Stevenson, members of the Commerce Committee. This is House File 3223, and I'm going to briefly describe what problem this bill addresses. There's been a lot of interest in this bill, and hopefully people will understand it in the short time we have. So the problem is that there's not a competitive market for biosimilars. It just doesn't exist today. And that's due to the rebate traps, rebate walls, and formulary exclusions. And these practices are very anti-competitive. So we need to even the playing field for biosimilars and originator biologics. The use of rebates provides incentives to PBMs to steer patients to costlier branded biologics rather than cheaper biosimilars. Biological medications account for close to 40% of total prescription drug spending. And in the last 5 years, brand name biologic drugs accounted for more than 90% of prescription drug spending growth. In 2018, the U.S. spent $126 billion on biologics, less than 2% of which was on biosimilars. In Europe, over 45 biosimilars have been launched with discounts of up to 70%. While in the U.S., the FDA has approved 24 biosimilars and only 11 have launched, with usually just a 35% below price market of originator biologics. So House File 3223 creates product parity for biosimilars and the reference biologic products by requiring equivalent coverage. This greatly reduces the risks and inefficiencies and eliminates a barrier to biosimilar use. So I'm going to introduce Andrew Askew. He's Vice President of Public Policy at Essentia, and then he'll introduce one of our testifiers.
Okay. Yes, and Mr. Askew.
Thank you, Chair Stevenson. My name is Andy Askew. I'm the Vice President of Public Policy at Essentia Health. Before I introduce our pharmacy team, I just want to take a quick moment to thank Representative Schultz for her work on this bill and for Representatives Hamilton, Munson, and Liebling for leading on this new and exciting issue. With that, I want to introduce our pharmacy team. We have Roseanne Hines, Senior Manager of the Office of Medication Use Management, and David Spurl, Pharmacy Clinical Senior Manager, who will explain the bill. And with that, I'll introduce David.
Thank you, Mr. Spurl.
Thank you, Chair Stevenson. Thanks so much for allowing us to come today and appear before the committee. My name is David Spurl. I'm a pharmacist at Essentia Health. I live from Duluth, Minnesota, and I was born and raised in Little Falls. I'm here with my colleagues today asking your support of House File 3223, a bill which allows providers to prescribe biosimilar medications in a manner that focuses on patient safety while also helping drive down the costs of prescription medications. So Essentia Health is an integrated health system that we serve patients in Minnesota, Wisconsin, North Dakota, and Idaho. We're headquartered in Duluth. We have 14,500 employees in our 77 clinics, 15 hospitals, and 7 long-term care facilities. An important point is that we're an accredited accountable care organization by the National Committee for Quality Assurance, and we're really focused on that triple aim of better health, improving our patients' experience while also lowering costs. As the committee considers this legislation, I'd like you to imagine that you're a patient who has debilitating joint pain or a new diagnosis of cancer. Your doctor, who you know and trust, discusses the various treatment options with you. prescribes you the medication that is not only best suited to take care of your condition, but also is the most affordable option for you. Understandably, you'd want to start this as soon as possible. After getting your prescription, you now find out that because your medication is a biosimilar medication not covered by your insurance company, that your treatment is delayed, and your doctor is forced to prescribe you a different biologic medication. Although this new medication is clinically exactly the same as your original prescription for you, it's far more expensive, and it requires you to pay more out of pocket. Finally, imagine that once you get the medication that's covered by your insurance, you find out that in changing the medication, your doctor prescribed the wrong dose due to confusion caused by the complexity of switching medications required by your insurance. This is the reality that our doctors, other healthcare providers, and patients live in every day with a class of medications called biological medications and their related biosimilars. Biosimilar medications are a new class of medications that have no difference in safety, purity, or effectiveness when compared to their brand biologic counterparts. These new biosimilar medications offer significant opportunity to drive down healthcare costs, much like generic medications have done for years, but for this newer class of biologic medications. Despite all this promise, as demonstrated in the patient example that we just highlighted and also discussed by the Institute of Safe Medication Practices, there are various safety concerns regarding the current payer-driven system for prescribing and dispensing biosimilar medications. For example, in order to satisfy the different payer requirements, a healthcare provider must ensure it devotes significant resources to maintaining a complex inventory of multiple versions of many different drugs. Due to the volume of different medications, there are increased risks of physician prescribing errors and also pharmacy dosing and dispensing errors. By requiring insurance coverage parity of all biologic and biosimilar medications, this bill will allow doctors and patients to choose the medication that's safest and brings optimal value to the patient. In addition to the safety implications, biological medications are the most significant driver of prescription drug spending in the United States. As Representative Schultz said, they've been cited to account for almost 40% of total prescription drug spending. Yet, the current system set up by medical and pharmacy benefit managers and pharmaceutical industry brand manufacturers has limited the ability for patients to benefit from these new medications due to rebate traps and other anti-competitive tactics. While some might cite these rebates as lowering costs in the short term, it's well documented how these tactics increase the overall cost of care, including out-of-pocket costs for our patients. At Essentia Health, we continue to work hard as an accountable care organization to provide high-value, cost-effective care for our patients and truly align with patients around reducing the overall cost of their care. We've worked closely with the physicians at our organization to review biologic medications and their associated biosimilars, and we utilize these medications many times every day. Unfortunately, due to different payer restrictions, not all of our patients are able to utilize these certain biosimilar medications and realize the savings associated with their use. So currently, there are 26 biosimilar medications representing 9 groupings of a brand and their associated biosimilar. With only a handful of these biosimilars on the market, it's understandable that the issue hasn't garnered the attention that some other issues have. This year, however, is slated to be a year of exponential growth in biosimilar medications, which is why we believe it's important today to continue efforts to facilitate the use of biosimilar medications in a manner that focuses on patient safety while also lowering costs. Thanks so much for your time.
Thank you. And I think that's the conclusion of the introductory testimonies. Representative Davids, I think, had a question.
We have one more testifier.
Oh, there's a member on the public on here. Do you have one more from?
It's up to you how you want to run the committee.
Okay, is it Mr. Forsberg? We'll take Mr. Forsberg's testimony briefly. Mr. Forsberg?
Hello. Good afternoon, Mr. Chair Stevenson and members of the House Commerce Committee. My name is Paul Forsberg, and I am the Director of Pharmacy for Minnesota Oncology and here to speak on behalf of Minnesota Oncology today in support of HF 3223. As background, Minnesota Oncology is the largest independent multi-specialty oncology practice in Minnesota, with over 80 providers serving in 12 locations around the Twin Cities. We see over 14,000 new patients annually and 127,000 patient visits per year. Our providers and their treatment decisions that they make have a significant impact on the cancer treatment for many lives within the Twin Cities community. In the last 20 years, we've made significant strides in the treatment of cancer in the community setting. As reported by the American Cancer Society, the death rate from cancer has declined by 29% from 1991 to 2017. The American Cancer Society attributes this progress to improvements in cancer treatment. Our medical oncologists are highly trained physicians who follow precision medicine driven by clinical pathways to identify and select the appropriate treatments for our patients based on their disease and treatment goals. We are now at a turning point in which biosimilar versions of the groundbreaking cancer treatments are available and, if managed appropriately, offer the opportunity to decrease costs of cancer treatment without impacting effectiveness or outcomes. When evaluating these new biosimilar products, physicians and the established pharmacy and therapeutics committees within our health systems are the best healthcare professionals with the most experience to select appropriate treatment for our patients. If insurance companies are allowed to continue to select and designate which therapies are appropriate for our patients, it may not always decrease the total cost of care, could increase the risk of unnecessary safety events in our clinics, and could negatively impact our patients' experience with their cancer treatment. Today, we have multiple examples in which the patient and the provider select the appropriate treatment based on that patient's disease, desired outcomes, and patient-specific factors, only to be later told that the drug they had selected would not be covered. These patients are then being told that they would have to try and fail the insurance company's preferred product. For our patients, trying and failing a drug isn't an option, as a fail is usually defined as progression of disease. Our physicians and our organization have taken pride in the fact that we select treatments for our patients based on the clinical evidence, the impact of the treatment on the patient's quality of life, and our patients' needs. Our physicians have never wanted to treat two similar patients with the same disease differently because the policy outlined of their insurance company dictates so. We now have scenarios in our infusion center where we have two patients sitting next to each other who both have the same disease, both have the same physician, and they're both getting different drugs because of those different policies outlined by their payers. HF 3223 seeks to address this problem by prohibiting an insurance company from requiring or demonstrating a preference for a biologic product when multiple options are available. We encourage the committee to support HF 3223 in order to uphold physician prescribing autonomy, optimize clinical outcomes and patient experience, and decrease unnecessary safety risks. Thank you for your time.
Thank you. And now, Representative Davids.
Well, thank you, Mr. Chairman. Is there anyone in the audience that has any concerns about this bill? I mean, this is a Schultz bill. You know it's good.
Actually, Chair Stevenson, may I comment on that?
Representative Schultz.
Thank you, Chair Stevenson. Chair Representative Davids. Well, this is actually model legislation. All states are going to be looking towards us, Minnesota, on this legislation because we're trying to tackle the problem of biosimilars. And if I had more time here, I would really explain the difference, or my experts would, on what the difference between a biologic and a biosimilar is, but and go into the details. But we're really doing something innovative here because the federal government has not moved forward on their PBM rebate rule that they were going to implement. So this will help us make the prices of biosimilars being more competitive and reduce the price by hopefully as much as European countries are seeing it by as much as 70%, which will hopefully lower everyone's premium. So I think we're all going to be better off if we start this in Minnesota, and there'll be a domino effect across other states when they implement the same thing.
Mr. Chair?
Representative Davids.
Basically, my question is, though, is there anybody in the audience opposed to this bill? Is there anybody signed up for opposition?
Representative Davids, there's no further testimony signed up. I will be asking the audience if there's any further additional testimony.
Because I used to have a rule when I chaired committees that if nobody was against it, why didn't even talk about it? I mean, have you ever read the book, Chair Schultz, Shut Up and Sell? No, it's a great book in sales. When you got the deal, cut the deal, go with it. But I guess there is somebody, and I would just like to say for our chairman, not that you're not doing a wonderful job right now, but please give Chair Halverson my best. Hope she's feeling better.
Well, thank you, Representative Davidson. I certainly will do that. We have 2 members on the list. If they have questions for the testifier who's here, we can take those questions now. Otherwise, we do have, it appears, one person who'd like to give public testimony. Representative Haley, was your question, did you have a question to the testifier, or did you want to?
Mine might be for the pharmacy.
Okay, well then, and Representative Howard? I
think more for the author.
Okay, in that case, we do have a member of the public who wishes to testify. If you could just come up, and we are really running tight on time here. We've been, have a 3-minute deadline that I'm going to have to be pretty strict on, so just put your name into the record and proceed.
Thank you, Mr. Chair. For the record, my name is Matt Schaefer. I'm the Director of Government Relations for Medica, and I'm not going to say oppose. I think one piece we want to testify is with concern. As we heard the other testifiers speak up, it sounded like their intent was to increase the prescription of biosimilars, and we share that goal. The average wholesale cost of a biosimilar is about 15% cheaper than a biologic. So as a carrier, we like to see biosimilars used more frequently when that's what matches the medical evidence. The concern we had in looking at sections 2.4 through 2.9 is just making sure that's what the language actually does. Just as I'm reading it, you could really, it just prevents us from, while the intent's to prevent us from moving people toward biologics, it looks like as we read it, you could also move people away from biosimilars to biologics. And so that's something we're happy to work with the author on, just making sure that if the intent is to increase the use of biosimilars, we share that goal and we're happy to work with you on that.
Chair
President Schultz.
Stevenson, happy to work with folks on improving the language. So we really want to move people towards biosimilars away from biologics. That's the intent.
Thank you, results. Thank you, Mr. Schaefer.
Thank you.
Is there anyone else in the audience wishing to testify? Seeing none, Representative Haley.
Thank you. I'm not for or against. I think this is very, very complicated and would just suggest that we need more time than today to digest it before we move it along. My specific question that I can't figure out yet, and maybe because, again, it's complicated stuff, how will this affect formularies? I mean, insurance companies, PBMs, employers, we use formularies to try to manage cost, but also the supply of how many different versions of a drug do you need to stock. So I'm wondering if you can address that.
And is that Mr. Spurl who's back? Mr. Spurl?
Yeah, thank you.
Yeah.
Yeah, thank you, Chair. So we specifically did not want to impact the ability to use a formulary. The desire is once a company would designate a medication on formulary that they would cover with parity the biologic and its associated biosimilars. So really continuing to make those appropriate, wise formulary decisions while also creating that competition amongst the products. Not, yeah.
Representative Schultz.
Yeah, thank you, Chair Stevenson. So right now, hospitals have to stock multiple biologics or biosimilars because every payer has a different product on their formulary. And oftentimes, they have to dispose of those that go unused, and it costs millions of dollars for one hospital that we all pay those costs. Those costs will get pushed onto other things. So in some ways, this will give more choice to hospitals to choose consciously cheaper biosimilars and possibly reduce waste, not having to dispose of unused biosimilars or biologics, and reduce the costs for all of us.
Thank you. Representative Haley.
Just a follow-up question, Mr. Chair. Then are you saying for every drug type, there is one biosimilar that matches it?
Mr. Spurl?
There are multiple, right?
Thank you, Chair. Nope, there's one originator biologic product and then multiple biosimilars. Up to, I think, 5 is the most of any one product right now.
Representative Haley.
Thank you, Mr. Chair, and thank you. So on the formulary, again, there will still be a choice as to what is included on the formulary,
Mr. Spurl.
what you're telling me.
Yep, this would not, thank you, Mr. Chair, this would not impact that formulary decision.
Mr. Chair, one final question. I know we're out of time. It looks like this bill applies for our public programs, Minnesota Care and MA, so I'm wondering if there's a fiscal note that is in the works or coming.
You know, this, Representative Schultz, I don't know if you can answer the question. Of course, this isn't a fiscal committee, but if you...
Sure, Chair Stevens, we have requested a fiscal note, so the next committee, Finance Committee, will talk about that.
Thank you.
Representative Howard.
Thank you, Mr. Chair, and I'll be brief too. And my question was a little bit on the lines of Representative Haley. One thing that we found in the insulin space, as I've been working on that issue, Eli Lilly announced an authorized generic. that reduced the price of their insulin in half. What we found is that basically no Minnesotans have access to that. And what the company has said, it's because this formulary issue and that authorized generic doesn't end up on formularies because there isn't the incentive for the PBM to have, their profit margin isn't as great. Does this bill get at that issue as well?
Mr. Spurl?
Yes, this bill would look to create parity, so those health providers would be the ones actually choosing between the suite of available products, giving the providers, the physicians, and patients access to make those decisions.
Thank you.
Representative Howard.
Thank you.
Representative Garofalo.
Thank you, Mr. Chairman. And Representative Haley mentioned this, but do you know what the timing on the fiscal note's going to be? I want to make sure, we got a huge fiscal note yesterday on a bill that came out of left field. So do you have any ideas when it's coming?
Well, the next stop is, thank you, Chair Stevenson. The next stop is HHS policy. When it gets to HHS finance, I think we will have a fiscal note.
Okay, and so
Representative Garofalo.
Mr. Chairman, Representative Schultz and Representative Howard actually kind of asked my question, and that is that the entire supply chain for this actually has a perverse incentive to drive up the rates. That I know, in my opinion, I think insulin manufacturers are unfairly targeted with this because they're not the ones who are getting the money. And it's really, it's something to see this going forward. I'm curious to see where this bill goes and how it goes forward, but I think you have the right concept of how to deal with this and basically cut out the middleman, cut out the administrative expense. You're capturing savings, and at the same time, you're providing greater quality of care to patients, which is exactly what we should all be looking for. But again, I recognize that this healthcare system is a giant Jenga stack, and you pull on one thing and other things happen. So, but thanks for bringing it forward.
All right, and there's no one else on the list, so if Representative Schultz, if you have closing remarks, we'll move to a vote.
Thank you, Chair and members of the committee. I want to thank everyone that has worked on this bill. This started last year, and really grassroots effort to work on the bill, so thanks to everyone. And I also want to note there's a letter in your packet from the Mayo Clinic supporting this, and it's going to come before other associations to, and hopefully we'll have more
Mr.
support
Chair?
in the future.
What clinic was that?
The Mayo Clinic,
Oh, from the mothership?
yes.
Thank you, Representative Schultz. At this point, I will renew my motion to re-refer House File 3223 to Health and Human Services Policy. All those in favor say aye.
Aye.
Opposed, say nay. The motion carries, and you're on your way. As we have no further items on our agenda, I will adjourn the meeting.